Okay, Alekos, you're muted if you want to get it rolling. Thanks.
Great. Good afternoon, everybody. My name is Alekos Theologis. I'm one of the assistant professors in the orthopedic spine surgery department at UCSF. And it's an honor to be able to speak to you tonight on cervicothoracic deformities, tips and tricks for surgical correction, no relevant disclosures. By way of outline, we'll be talking about, at its basic, what is cervicothoracic deformity, why do we treat it, then go into surgical tips and tricks, and then end on the last half an hour with interesting case presentations. Those will be led by our three current fellows, Ali Maziad, Amir Udarzi, as well as Ravi Srinivas. And again, thank you to the Seattle Science Foundation for this opportunity. So what is cervicothoracic deformity? And at its core, it's really any malalignment of the cervical and or cervicothoracic spine that results in a functional disability as a result of neck pain, neurologic impairment, and or difficulty performing activities of daily living. And in order to understand what the abnormal is, we really have to define the normal. So normal posture at its simplest is standing straight up, but really the goal is to maintain a horizontal gaze. And that horizontal gaze varies depending on what our activity is. So walking requires head to be down several degrees, even further if you're sitting at a desk. Now, in the age of iPhones, that posture may be even more exaggerated. But really, as you can see, the majority of our life is at the equator or below the equator. And it's been demonstrated that there's kind of a sweet spot of head position. And this is in the setting of if your head is fixed, so you have an occipital cervical fusion. There's very low disability on the NDI scoring system if you have about 5 degrees north of the equator to about 20 degrees south. However, you can see on the ends of the spectrum here that when your head is fixed, looking more towards the sky, above that 5-degree mark, the higher it gets, the more disabled you become. And even, and then the opposite is true. So below 20 degrees of flexion, your NDI becomes considerably compromised. So there's multiple ways that you can measure neck alignment, and in terms of cervical lordosis, cervical sagittal, the SVA, but we can't just focus on the neck and its alignment. We really have to focus on the full spine because the top is affected by the bottom and everything in between. I think this flag post example is a good example of that. This has been demonstrated by numerous colleagues, first showing correlations between pelvic incidence, lumbar lordosis, thoracic kyphosis, cervical kyphosis, cervical lordosis, excuse me. We studied this when I was a fellow at WashU and tried to define it based on subtypes. But the core of it is that the bottom affects the top. Lee et al. In 2015 put out a nice article that really demonstrated that T1 slope was a key factor determining the cervical spine sagittal balance. And so I wanted to walk through, I think this is the crux of this talk, and it's really defining radiographically the differences between a subaxial based pathology, a thoracolumbar based pathology resulting in cervicothoracic kyphosis or deformity, and a combined deformity. So if we look at this little gimmick of the spine with T1 slope as the equator, anything above T1 will be, an axial or subaxial deformity. Anything below will be the upper thoracic based deformities, thoracic and lumbar. And so if someone has a subaxial deformity, as you can see here in the two pictures, what happens with this pathology is they lose lordosis of the cervical spine, and then they try to compensate by hyperextending through the occiput to C2 or occiput to C1 area. And so radiographically, these patients will present with a high C2 tilt, and that's a demonstration of that compensatory mechanism in the upper cervical spine. And they'll have a low T1 slope. And again, this T1 slope is the key factor here. The converse is true for thoracolumbar based pathology. So in this, you see a patient who can have either upper thoracic hyperkyphosis. And in this setting, their compensatory mechanism a lot of time is to hyperextend their cervical spine. This is also the case for someone who has flat back from whatever etiology. Again, their head is pitched forward, their global SVA, and the way to maintain their horizontal gaze is to hyperextend their subaxial spine. In this case, you can see the T1 slope ends up being high, greater than 30 degrees, and then their C2 tilt is low because their compensation really is through the subaxial spine, not so much from the upper axial spine. These are good examples of thoracolumbar-based pathology that can result in a cervicothoracic deformity. You see the congenital kyphoscoliosis in the left two images, and then you see flat back in the middle image, and then what appears to be also a degenerative based lumbar disorder. When you have combined pathology in the subaxial spine as well as a thoracolumbar spine, you'll have a mix of the two. Again, here the main compensatory mechanism is through the upper cervical, so the axial spine, so it's going to be from OC to C1. That results in a high C2 tilt, and because of the thoracolumbar based pathology, you'll have a high T1 slope. These are a couple examples, patients who have a flattened subaxial spine combined with distal junctional failure. And then that's the two left images, and then the right image is a patient with a ankylosing spondylitis. You see he has a subaxial kyphosis, as well as loss of lombardosis with a concomitant pathologic L4 fracture. So why do we treat these deformities? And it really gets to the question of what's the disability that's associated with them. There's more and more literature that demonstrates and clearly demonstrates that cervical sagittal malalignment, particularly the C27 SVA, drives a lot of the neck disability. You can see a study by HSS as well as Dr. Ames here at UCSF that demonstrated that increasing C27 SVA resulted in increasing NDI scores. And around 4 centimeters or so, that's when people really start to become more affected by this. Another nice study from the International Spine Study Group in 2017 from neurosurgery found that adult cervical deformity was among the chronic conditions that affected the EQ5D. This is the most. So the bottom 25th percentile, so extremely disabling conditions from a global functional standpoint, not just based on the NDI. You can see that it's up there with emphysema, renal failure, stroke, heart failure, blindness, CAD, metastatic breast cancer, and prostate cancer. So extremely disabling condition. The reason why it's so disabling is a variety of factors. When you get to the point on the right, clearly this affects maintaining horizontal gaze. Eating can be compromised. You're going to get a chin on chest deformity, breathing. But in the more mild deformities you see on the left, just having your head pitched forward, so increased C27 SVA, that puts a lot of stress on the paraspinal muscles, the trapezius. In order to maintain your horizontal gaze and keep an upright posture, really requires a lot of compensation through those paraspinal muscles. Over time, patients can develop a webbed neck, and it becomes very, very fatiguing. Very similar to what happens in the thoracolumbar spine with a flat back. And then in the setting of subaxial kyphosis and any kyphosis in the region of the spinal cord, kyphosis ends up resulting in thinning of the spinal cord, and myelopathy sets in. So there's a radiographic malalignment that's a problem, but also the malalignment, it has a negative effect on the neural elements. So when we get to surgical treatment, the real keys are to focus on the flexibility of the deformity, which can be assessed by supine radiographs, or say a scout CT, it's a serendipitous supine assessment, or even on an MRI, and also defining clearly what the location deformity is. Now, we'll go through a couple case examples in the next couple slides. But because this talk is on cervicothoracic deformities, we'll focus primarily on the thoracolumbar region. So very, very simple, flexible or unfused deformities, posterior column osteotomies can be used. But if it's it's greater severity deformity, a 3-column osteotomy often is necessary. If it's a rigid deformity, then a 3-column osteotomy definitely is the workhorse and a necessity. So this is a patient of mine that had a T3 to L2, L1 posterior instrument infusion by an outside physician. She did well initially, but then over time started noticing this hump that developed at the upper part of her back and just felt like her head was thrusting forward and dropping down. You can see here that what occurred is she had some residual kyphosis from that compression fracture, but she developed a proximal junctional fracture at T2. That resulted in a high T1 slope, as you can see there with 48 degrees in the middle image. And then if you look at her subaxial spine, her C2 tilt is relatively low. So we know that this is a upper thoracic or deformity that originates below T1. So because it wasn't a rigid deformity, and when she laid down, her deformity seemed to correct some. Sorry, I don't have the supine radiographs to present. We extended her up to T1 and did some posterior column osteotomies at T1, 2, and T3. And her T1 slope, as you can see here, normalized. And she was very, very happy. You can see that upper thoracic hump on the radiographs is no longer present. If we get to the more rigid deformities, so this is a patient who presented from outside hospital with nearly chin-on-chest deformity with a prior C3 down to T1, developed this, you can see this is kind of a combined deformity because it's flat to the subaxial spine. So she's got a high C2 tilt, but also has a high T1 slope as a result of a distal junctional fracture and infection. In this case, we elected to proceed with a T2 PSO and extended down to T4, and he did quite well. Just a couple of case examples to highlight the different surgical options for flexible versus more rigid deformities. So then it gets to the question of what's the ideal location of 3-column osteotomies for addressing these cervicothoracic deformities. And when I was a resident in conjunction with Johns Hopkins, Dr. Kabesh, as well as Dr. Ames and Dr. Shane Birch, who's on the line with us today, Dr. Devrin, we looked at 48 patients who underwent either a 3-column osteotomy at C7 or in the upper thoracic spine. We found that the C7 PSOs performed better in terms of sagittal realignment. However, they had a very, very high complication rate, and the upper thoracic osteotomies had a lower complication rate, but while slightly less sagittal realignment ability, was not something that compromised the radiographic outcomes and the clinical outcomes. I have to thank Dr. Ames for this slide. Initially, our experience was doing osteotomies at C7 or T1. However, doing osteotomies at those 2 levels results in very, very high rates of C8 palsies. You can imagine that it's extremely disabling to patients to have, essentially a claw hand after surgery. So you can see here in this slide, 16% at C7, at T1, 43%, and then at T2 and T3, that significantly drops off. The etiology for this is not completely clear, but it may be due to when there's realignment of the cervical spine sagittally, the C8 nerve tense over, the lower brachial plexus tense over the T1 rib, even though it may be removed as part of a T1 osteotomy. There's something has to do with this area and the C8 nerve and lower brachial plexus. So we really don't do osteotomies at T1 anymore if we can avoid it. So after you've chosen which level osteotomy you'd like to perform for the correction, the next questions are, where do you stop? and where do you stop proximally, where do you stop distally to prevent and hopefully minimize the risk of DJK as well as that of PJK. And so the question first is, where do you stop the lower instrumented vertebra? I don't think there's an exact answer to this. There's a nice study from the ISSG that demonstrated that for patients who have cervical SVA correction that's 4 centimeters or greater, or you anticipate that that'll be the case, a high T1 slope, a global SVA greater than 8 centimeters, and an upper thoracic osteotomy, 3-column osteotomy, that's stopping below the thoracic apex at T9 or T10 is maybe a better way of preventing DJK. I know from our Sherman's kyphosis literature, the stable sagittal vertebra is one that is advocated for. And so for those, just as a review, there's different ways of choosing the distal, the LIV for Sherman's kyphosis. And if you draw a vertical line up from the posterior aspect of the sacrum, it's really going to be the one, the vertebral body that it bisects, or even maybe just slightly touches. And so I don't know if it's the right way to choose it for these cervicothoracic deformities, but it's something that you should consider. In addition to choosing the lower instrumented vertebra, as we do in the, many people do for thoracolumbar deformities for PJK, PJK prevention due to fractures, cementing the most distal level in those settings has proven helpful. I think that's also a reasonable thing to do in the setting of the LIV for correcting these cervicothoracic deformities. The reason for that is there's a huge cantilever stress that occurs at that LIV. So if you cement augment it, possibly that could prevent those screws pulling out. Now, when it comes to the upper instrumented vertebra, I don't think we know what the best area to stop is. Cervical lateral mass screws, especially in patients with poor bone quality, don't have great fixation. So very high risk of what you see here. Not only is there a risk postoperatively, but it can actually happen intraoperatively with deformity correction. So some people advocate for getting a solid anchor at the top, which would be C2 if you can get nice C2 pedicle screws, or at least good large C2 par screws in. That may be a way of preventing this. I'm not advocating for this because I think this is a relatively high risk and some people would argue dangerous fixation method in the cervical spine. But cervical pedicle screws are a fixation option. You can see here biomechanically they have a higher resistance to pull out compared to lateral mass screws. They're challenging to place freehand. Dr. Birch and I wrote a series of his in 2015 of nearly 40 patients who had subaxial pedicle screws placed with intraoperative navigation. I'm not advocating for one navigation system over another, but if you are planning or want to place pedicle screws, this is something that is feasible. And Dr. Birch is on the line tonight, so if you have questions about this, he's a guru in terms of placing, using navigation in the cervical spine. There are some nuances to it because of the mobility in the subaxial spine. So now that we've decided where we're going to do our osteotomy, where we're going to stop proximally, where we're going to start distally, now we have to know how to correct it. And the traditional methods for correcting it are through segmental compression or cantilever bending. Segmental compression a lot of times involves placing a rod holder over that area that we did the osteotomy, and then compressing at the screw superadjacent or subadjacent to that osteotomy site. Cantilever bending is a technique that is very commonly used to correct kyphosis. You fix proximally, set multiple levels above, and then you under contour the rod and bring it down to the other side of the osteotomy. This can be done cranial to caudal or caudal to cranial. No real preference there. However, especially in patients with poor bone quality, severe deformities, there are pitfalls to using cantilever bending and segmental compression. Place the screws under considerable stress. You can have screw pull out and screw plow, which if you lose your screw fixation, your deformity correction is actually can certainly jeopardize and won't be able to be performed safely. And this is particularly true in patients with poor bone quality, the elderly patients, the majority of whom are getting these deformity corrections. So is there an alternative? I learned this technique and I'll present it to you. I've modified the one that I learned from Dr. Gupta, but it's what we call the rail technique. And I'll walk through the individual steps of it to demonstrate why it's called the rail and why this is my go-to surgical technique to correct cervicothoracic deformities. So this is a concept that really stems from the orthopedic trauma world, where we compress across fractures to help them heal. And just to give you the nuts and bolts of this, what this involves is fixing the fracture. And you can see with screws in the middle image on the left with the black, those are the screws. You fix them proximally or fix them on one side. And then you place the other screws on the other side asymmetrically in the holes. And as you bring down the screw, it then pulls the plate and compresses. So what this does is that it distributes stresses across all the screws. And so you have essentially an unblocked shortening of that entire left bone, and then it pulls over to the right side. And that's essentially what I'm going to talk to you about in terms of the rail technique. It's a little different for spine. So in this setting, what you do is you place your instrumentation. I would say if you're doing a 3-column osteotomy, at least 3 levels above, at least 3 levels below in the upper thoracic spine or mid-thoracic spine. You place small rods on each side above and below, and then you secure them all with set screws. Then you place these accessory rods, and these are the rails, through rod-to-rod connectors, either on one side or both sides, as shown here. And then the third step is essentially going to involve securing one whole side, like we saw in the fracture. So, first you tighten all the midline screws, as you can see in the red box. And then you tighten one side of both accessory rods, and that stabilizes that one side of the spine. The next thing you do is that you loosen your set screws on the other side of the accessory rods. And so now you can really use the rails, as your shortening rails. If you want to shorten through the rods, you can place a rod holder as you would normally, and then compress along the W connectors or the rod-to-rod connectors laterally. And this allows this entire proximal segment to shorten unblock. It's very, very controlled. There's no risk of translation, really no risk of, because you have 2 rods on both sides, you're not going to get any unforeseen neurologic consequences from this. I wanted to show this example via video. So this is a patient of mine who she has multiple myeloma. She came in with subaxial kyphosis from a lesion at C3, C4, and C5. We did a 3-level anterior corpectomy and then C2 to T2. About 6 months post-op, she presented with this cervicothoracic deformity from distal junctional fracture. It was rigid. So what we did is, this is the nice thing about a rail technique too, is we cut the rod between T1 and T2. We took out the T2 screws. We then instrumented from T3 down to, I believe, L1. We didn't do anything to the upper cervical spine, the subaxial spine. Then we placed our lateral rods, the rails, through 2 Ws, and you can see here the Ws proximally, cranially, as well as those distally. And then and 2 rods are, the rods in the subaxial spine, those in the thoracic spine are not connected except for these lateral rods. So you loosen the ones distally on both sides, and then place a rod holder. And the shortening's subtle, but this is just to demonstrate the technique. And that will allow you to bring that whole cranial segment and shorten across that osteotomy site. Very, very powerful, very, very safe. The other option for this rail technique is to use the rail, the accessory rods, as a cantilever maneuver. So if you're going to do this, do something similar where you lock that rod, the accessory rod, the Lauer rod, in either cranial caudal, you under contour it, and then you can push it down into the W's laterally. The nice thing about this is you don't have to worry about any screw pullout because everything is secured medially. And so it really puts no stress on the screws. So this is the same patient. We did a similar thing. You can see here, we under contour the rod. You see it's above, aiming straight up. And then you bring it down. Again, it's subtle, but it definitely is safe and effective. And so this is a good, that's the deformity correction that we got. Focus on the right side. The rails can also act as your final rods. So in this case, we didn't have to mess around with taking out the old rods, putting transition rods in, and fooling around with going from C2 down to L1. We were able to break it up into different segments, the subaxial spine, thoracic spine, and just use our rails to correct that regional and local deformity at T2. This is another patient who we used the rail technique on, a very sick woman with rheumatoid arthritis, end-stage renal disease. So I had about 4 or 5 neck operations. You can see multi-level anterior cervical, fused from C1 down to T2 initially, developed a distal junctional failure. We then was then extended down to T4. So when presented to us, you can see she has this kyphoscoliosis, very severe rigid deformity, chin on chest. So in this case, we did very similar rail technique. We didn't expose the entire subaxial spine. We took out the rods from where the dominoes are at around T1, took out those T3, T4 screws, put new screws in, and then instrumented from T5 down to I believe at L2. And we planned on doing a VCR at T4. And again, we broke it up into subaxial spine, thoracic spine instrumentation, then use our rails for all of our correction. And so with this, that we achieved our goal of restoring her horizontal gaze. And again, this was all done through these rails. You can, it's difficult to close the skin if you're concerned about, the rods being too lateral. You can always switch it off to more medial. If you want, you can take out the accessory rods altogether, clearly one by one, and replace it with longer rods in the midline if you want. There's a lot of varieties, but I think this rail technique poses several advantages. It provides controlled compression across a 3-column osteotomy site, minimizes translation given multiple fixation points above and below. You can also achieve asymmetric compression across a 3-column osteotomy site. You can compress on the left side more than you on the right. Or in the last example, the converse to correct that coronal deformity. I think the key thing here for this technique is it minimizes bone screw interface forces. You have no direct compression across any individual screw. You either slide along the rails or you have the cantilever maneuver, and all the stress goes through the W's, which are connected to the rods. And then finally, the temporary rods can act as your final rods. So in conclusion, before we move on to the interesting cases, cervicothoracic deformities are very heterogeneous. The key here is to define where the deformity is based, either in the subaxial spine, thoracolumbar spine, or both. Keys to determining this is evaluating your T1 slope as well as your C2 tilt. Subaxial spine deformities have a low T1 slope and a high C2 tilt. The thoracolumbar deformities have a high T1 slope and a low C2 tilt. And then if it's a combined deformity, has a high T1 slope as well as a high C2 tilt. They're very disabling in terms of quality of life, both from the radiographic malalignment as well as the neural tension and associated symptoms. Surgical strategies really should be tailored to the deformity, assess the flexibility, really define the region of the deformity. Once you've decided on what type of surgical correction you're going to perform, if you're going to do a 3-column osteotomy, in the upper thoracic spine, I would recommend doing a T2 or T3, but really focus it at the deformity. Again, T1 or C7 3-column osteotomies have a high rate of C8 and T1 radiculopathies. Choose your levels proximally and distally to minimize the risk of DJK and PJK, as discussed before. And then in my hands, the rail technique is safe and efficacious. And I think it's not meant to replace the traditional techniques. It's just another tool in your toolbox to help address some of these challenging deformities. So I'm happy to take any questions, but I would like to get to the interesting cases. So I'm happy to.
This is Izzy Lieberman. Just a couple comments.
Yes, sir.
These are the most challenging cases ever. There's no doubt in my mind that cervicothoracic junction is a big, huge challenge, and those that are willing to take it on, as you have pointed out, have to be very meticulous in it. Two things that I would add, and maybe I missed it in what you were saying, but I still rely very heavily on preoperative traction for these patients. You can get a lot of passive correction with this. And quite frankly, that helps me decide just how extensive the surgery's going to be. Sometimes these are staged anterior posterior, sometimes it's multiple days, sometimes it's osteotomies, and you just have to be very, very creative. Another thing that I have really become a big fan of over the years has been the pneumatic headrest in terms of positioning the patient and getting the corrections at the time of surgery. The rail technique is brilliant, and there's all sorts of modifications to that. But when you've got that pneumatic headrest with the handlebars, you can actually get your screws in safely with the head forward flexed, and then do your osteotomies and bring it up in a controlled situation and not really stress your instrumentation as much. The anesthesiologist has to be on board with you with it because they've got to look at the tube, and there's all sorts of things. But that has been probably the single biggest advantage that I've had the last 5 years since I've been using that in doing these complex cervicothoracic deformities.
Thank you for bringing both those up. Those are excellent points. Yeah, traction is very important for these, and that head holder, I agree with you. That's been a game changer, and we use it here as well. So thank you for bringing that up. I did not include that in the talk. So let's move on to the interesting cases. And we have our three fellows who have kindly put these together. So thank you guys. We'll first start with Ali Maziad. He's actually from Egypt. He has extensive experience in spine surgery. It's been a pleasure to work with him. So Ali, thanks for putting this together. And I'll go through the slides. I'll advance.
Yeah, you're in control there. All right, so this is a case of Dr. Birch. Actually, it's cervical pathology more so than a cervical deformity, but I think it's interesting to consider as well because it's pretty complex. So this is a 62-year-old patient who's had presented with 6 months of neck pain and left arm pain, no weakness. She had prior history of breast cancer with metastasis to the cervical spine, has been treated with radiation therapy only. On her presentation, she's been doing fine with radiation. However, 6 months prior, she had that presentation of neck pain and left arm pain and no weakness. She still worked as an accountant at the time. Next slide, please. And her exam was pretty benign. She did have a little bit of a lower quadrant pain in the neck, but no mass could be felt. She had normal gait, 5/5 motor power, no sensory deficits, and no abnormal reflexes were elicited on exam. On her images, you would see her alignment is pretty normal, except a little bit of an SBA you could see in the sagittal for the cervical spine, a little bit of a cervical tilt to the left side, but not a gross deformity on X-ray. So she needs to get more advanced images, obviously. And That's again the X-ray showing a little bit of an SVA there. I think it's a little bit close to 4 centimeters. Next slide, please. And now the CT scan would see a destructive lesion involving the C7, T1, and T2 levels. And she has a little bit of numbering error if you count from the above versus from the lumbar spine. Next slide, please. You can see the multiple lesions involving C2, C7, T1, and 2. And if you actually count from the lower spine, it would be involve T3, T2, and C6 even. But she has a very kyphotic deformity at T1 and completely collapsed like a vertebral plane at that level. Not much compression of the cord. That's why we don't see a lot of neurologic deficits in her exam. Next slide, please. Again, presents the same thing. So that's the CT scan. You can see the numbering. So T was involved, C2, 3, 4, 5, 6, and starting C7, T1, T2. It's completely destroyed on the CT scan. And again, the cord was not too involved. So I think what would be the ideal management at this point, like anybody from the audience could chip in here.
Amir, do you want to take a stab at? We can also just move forward and save the pimping.
Yeah, sure. No problem. Okay, so actually it was a pretty involved surgery. She did an anterior corpectomy from C7 to T3. Obviously ENT and cardiothoracic were involved. She had to do a sternotomy to get that axis. And then from the back, she had a C2 to T12 posterior fixation and also cement augmentation for the LIV. And I think the next slide can show something like her ODIs were much improved afterwards. You could see in the CT scan. She has pretty good alignment and cage was filled with bone. I was not sure about her post-op images. They're not there, like long-term. It was done recently. But she had pretty good outcomes, and her ODIs and motor function was pretty well preserved after surgery. So it's not much of a deformity case as much of a pretty tough pathology to deal with. It involved corpectomy and multiple levels, and also understanding the concepts of deformity correction to have an overall good alignment for her after surgery.
Yeah, I think this is a really good case of an upper thoracic deformity. And we saw in the pre-op x-rays the high T1 slope as a result of that pathologic fracture. And her neck was starting to settle into her chest. And this is a beautiful outcome. I think it highlights also several of the points that were brought up in my talk. One is, in a tumor patient, you want to get multiple levels of fixation above and below, but these upper thoracic deformities, that's even more so the case. Dr. Birch, as you can see, placed several pedicle screws in the cervical spine at C4.
Yeah, I believe there are multiple pedicle screws. That's two, obviously.
They've got a really good foundation proximally in C2. Also, stopped below the thoracic apex at T12, and you can see there really full vertebral bodies filled with cement at the LIV, but also the LIV -1.
Plus one. I think the one below two was cemented, yeah, -1.
So I think a really beautiful outcome. If Shane, if you're on the line, any thoughts? He may not have been able to join us today, but thanks for nice, really nice case. And you can see here at following outcomes, terms of neck pain and arm pain. Started off preoperatively with extremely high NDI, 54, high neck pain. And then you can see here about 6 months post-op, the NDI is in the mild range. So I think that was a really, really beautiful outcome. So we'll move on to the next one. This is going to be presented by Ravi Srinivas, another one of the spine fellows who's done a wonderful job this year. He's going to LA for his job, and he's going to present a case of Dr. Burden's, one of my colleagues. So Ravi, go ahead.
Okay, so this is a 70-year-old woman. She comes in with right hand weakness and pain and right leg pain. This has been going on for the past week. Before this, she was able to walk without a walker, but now she's using the walker to ambulate. She had recently, in February 2021, C2 to 5 posterior laminectomy decompression and fusion. Other pertinent history, she has Parkinson's, osteoporosis, and also to note she's had a lumbar decompression in the past, has had a history of MI and hypothyroidism. So important to note here, right upper extremity, she is weak diffusely compared to the left. On the right lower extremity, diminished sensation, and she has upper motor neuron signs, right ankle, 3 beats of clonus, and bilaterally 3+ deep tendon reflexes, patella and the ankle. So this original surgery, the C2 to 5 decompression and fusion, was done at the done in an outside hospital, and now she comes in like this with the C2 and C3 screws have pulled out. There is also a region of olesthesis and 30-degree kyphosis at this focused more so at this junction of C3, C4. And next slide, and then this is the CT scan done again, just showing the screw pull out and the pseudarthrosis. And the MRI showing the at C3 for the central stenosis, which is probably accounting for her myelopathic symptoms. So the patient was then, about a week later, was taken to the OR for a 2-stage procedure. Stage 1 was a C2 to 5 ACDF, and we see an improvement in the overall cervical kyphosis, bringing the neck to about neutral lordosis. Then the next slide. And then a patient returned to the OR for part 2, C2 to T2 posterior fusion decompression. There was a small durotomy that was repaired. Again, we see a improvement in that cervical kyphosis. We now see 0 degrees of lordosis.
Hey, Robbie, pause there for a minute. I just want to go back. Izzy, you were talking about preoperative traction. How do you decide? Maybe show the CT scan from the original. This is her original presentation. Izzy, how did you decide when to do preoperative traction? Because this is one that I might have considered that on. But how do you decide?
I'm looking to figure out how much passive correction we can get. Sometimes you get that impression just on the differential between upright x-rays and the supine CT scan. If I suspect that there's more there than what I can tell on that, then I will gently do a traction x-ray on them first and see what's going on. The severe ones, I'm far more liberal in putting them into traction, giving them a couple days and letting the muscles rest, give them a little Valium. So this one, I must admit, I don't know that I would have used traction preoperatively on her, but certainly more of a cervicothoracic or a chin on chest. I'm going to try it ahead of time and see what we can get. You really don't lose anything with it.
I always say when there's a vacuum disc that's an invitation for me to do something in the anterior column. And in this case, the actual plan was to do a C4 corpectomy, and we were able to actually get, as you saw, the 3-level discectomy and fusion. But the original plan was to actually do a corp at 4. But we got a reasonable reduction with this and the anterior realignment.
Yep. And then
yeah, that's a brilliant result on that one. You got her back where her head needs to be.
Mm-hmm. And then we have some standing films here.
More to it coming.
Yeah. So this is Yeah, this is our Scoli film, but this is just focusing on the neck. We'll go over the full films in a second. But so we have about 20 degrees of C2 to 7 lordosis, a 40-degree T1 slope, and positive 6.5 centimeters CSVA. Then this is her using the steady to stand for Scoli films. It's important to note here that specifically at T1 to T3, we have about 10 degrees of kyphosis. The thoracic kyphosis is about 60 degrees, lumbar lordosis 60 degrees. The SVA is 0, and there's a small 15-degree thoracolumbar coronal curve. Go to the next slide. This patient did have a complication after surgery. Remember, they did have a small durotomy that was repaired, but they had a small superficial fluid collection. This was drained in IR. Cultures grew out MSSA, and cefazolin and rifampin started. Then this patient came presented like this with this T2 failure and a distal junctional kyphosis. Now the T1 slope has now drastically increased to 80 degrees, and the CSVA is 10 centimeters. Next slide. And then this is just her overall alignment. We see at T1 to T3, there's about 50-degree kyphosis across that junction. Next slide. Yeah. This is just the CT scan, better showing that T2 fracture. Next. Okay. And then our MRI showing the central stenosis here at that junction and that epidural collection there. Next slide. And then
So some remarkable flexibility there between this is what you were talking about is the standing film versus the supine film, and some remarkable flexibility. Maybe go back, Ravi, to the
So this is so there is the fracture does partially reduce on the significantly reduce on the MRI link.
Yeah, so you can see the difference there. She was neurologically intact with this distal junctional kyphotic issue.
Right. From what I understand, the exam did not change.
There's no new deficit. When she presented originally, she had some significant weakness. So there's no new deficit. In fact, her upper extremities were actually stronger than her original presentation.
Yeah.
I'm always amazed at how some of these, the spinal cord just doesn't even get affected, and others come back to you completely off, and it just scares me to no end. And this is the where do I start and where do I stop? I have no idea what the answer is anymore. You go too long, you get an infection. You go too short, you get a distal junctional issue. You can have two philosophies here. One, you can do what you did and have multiple revisions, so you look like a terrible surgeon. Or two, you just go ahead and do an occipital pelvic instrumentation infusion and be done with it and look like a real rogue surgeon. So take your pick with these cases. I don't know what the answer is anymore.
Mm-hmm. Yeah, so somebody pointed out in terms of a plan, or I guess you could show it, it's fine, is what about the bone density on this patient? I got involved after the original failure, and the bone density certainly is an issue. I think for some of these patients, this wasn't an elective case when it came to UCSF. It was an urgent case with a progressive neurologic deficit, but certainly for elective spine surgery, when to say no might be appropriate here. You got something with Parkinson's disease, osteoporosis, significant other comorbidities, hypothyroidism. So when to say no is really a big question in elective spine surgery. And had this been elective, probably would have put it off, but that really wasn't an option in somebody who presented with a progressive deficit. Someone else asked the question of when to go front to back versus back front back. And in this instance, at the presentation, there really wasn't any fixation in the back at all. That was a hold in her deformity. And certainly, if the instrumentation is holding her deformity, then my approach is what I call a back front back. What I mean by that is taking out the instrumentation in the back, re-instrumenting in the back with perhaps even posterior osteotomies, and that's one day. Then another day, go front and then hook it up in the back again. So I call it a back front back if the posterior instrumentation is holding the deformity. But in this case, it was front and back because the posterior instrumentation was basically in a brace.
Mhm. Okay, so this is where we returned to the OR, and the patient had a T2 VCR and a C2 to L2 posterior fusion deformity correction. Also, OR cultures were taken this time, and they were negative this time. So the cefazolin rifampin was continued for the previous MSSA from that previous superficial fluid collection. But now we see that the lordosis is 5 degrees. The T1 slope again is improved to 35 degrees. CSVA also again improved. Now it's a 4.5 centimeters. The kyphosis along T1 to T3 also significantly improved. It's down to 10 degrees now. The overall SVA improved 1.5 centimeters positive, and the pelvic tilt is 30 degrees. So there is a component of pelvic compensatory mechanism there. And then that coronal curve in the lumbar spine is also straightened out too. And then we have another follow-up for her. Okay, I guess that's the last one. So, but we had a follow-up about a month later, which she looked about the same.
So now the strategy, maybe go to that post-op just briefly if we have another minute here. I want to give Amir his chance, but again, as Alekos had suggested, lowest instrumented vertebra is the one that's touched by the posterior sacral line. In general, I would have cemented that LIV. We actually had some discussion about that, and because you had a history of MSSA, we washed it out, and it didn't seem to be infected at the time of this revision. But at the same time, I was concerned about cementing with a history of infection. So in this case, we didn't use cement, and so far that's holding up reasonably well.
Really tough case, but it looked like a really nice outcome. As you've always taught me, don't give up on your patients, and this is a good example of that. So I'm going to hand over the slides to Amir. He's our neurosurgery fellow this year, comes to us from UC Davis. It's been a real joy working with him as well, and he'll be presenting a case of mine. So I'm going to stop sharing real quick, and so he'll take over. Go ahead, Amir, take it away.
Thank you, Dr. Theologis. So today we're going to be presenting another case. This one's moderated by Dr. Theologis. It's a 55-year-old man, history of prior multiple anterior and posterior cervical fusions in outside hospitals, who presented to our ED with progressive neck pain, bilateral upper extremity paresthesias, and difficulty with his posture. Mainly, he was unable to keep his head upright. His exam just showed generalized weakness, 4 out of 5 strength in all extremities, decreased sensation to light touch in the uppers, and increased tone in all his extremities, with history of neurogenic bowel and bladder. His posterior cervical incision did show erythema and fluctuance, and was concerning on exam for infection. He has a past medical history of Hep C, hypertension, methamphetamines use, which he was positive on his UTOX and on presentation, and a history of heroin use and AFib. His prior surgeries in 2012, he had an emergent C2 to 6 laminectomy for an epidural abscess evacuation, and then that was followed by 2015 outside hospital surgery, which was done for post-laminectomy kyphosis, and also a C4-6 osteomyelitis that required a corpectomy and C2 to T2 posterior fusion. So on presentation, his x-rays here demonstrate a focal kyphotic deformity in the mid-cervical spine, along with signs of distal junctional kyphosis and failure. He's got a chin brow, chin on chest deformity with a significant CBVA. So I'll share briefly how we got here. So we didn't have the x-rays from the 2012 surgery, but the 2015 presentation where he presented with post-laminectomy kyphosis and his osteomyelitis. The CT here demonstrates the mid-cervical kyphotic deformity, along with remodeling of the end plates and a significant prevertebral swelling. An MRI at that time demonstrated a epidural fluid collection along with some prevertebral swelling and signs of myelomalacia, which was concerning. And so at that time, he went to the operating room at the outside hospital where they did a C4-5 corpectomy, anterior plate fixation, and they were able to restore his alignment fairly well with a C2 to T2 posterior fusion. So coming back to today, again, as I mentioned earlier, his CBVA was 31 with this focal 35-degree kyphotic deformity in the mid-cervical region, and also a C7T1 oleostesis, which showed this focal cervicothoracic distal junctional failure. On the CT, you see this T1 and T2 screws have been pulled out bilaterally, although the corpectomy looks like it's a solid fusion. And then the proximal end of the construct, also the C2 screws, which were PAR screws, appear to be now in the joint between C1 and 2. An MRI was done at that time as well, which shows, again, redemonstrates the C7T1 area of kyphosis and oleostesis. And then you actually see a epidural fluid collection at C7 towards the upper thoracic spine, which was concerning for infection. And then soft tissue area, you also see some changes of hyperintensity and fluid, which is concerning for infection as well. So in summary, this gentleman had a prior C2 to T2 posterior instrument fusion and C2 to 7 laminectomy, and then C4-5 corpectomies. He presented to us with distal junctional kyphosis, screw pullout at T1-2, along with this epidural abscess, and obviously the spondylolisthesis at C7T1. So since we're running short on time, I'll go ahead and just go to our plan. So in order to correct him, we performed a C2 to T10 revision posterior instrument of fusion. And to achieve the deformity correction, we needed to do a T1 PSO on him. And the anterior construct, given the corpectomy was healed, was kept intact.
Yeah, thank you, Amir. Again, a good example of a couple of factors here. One is, these high-risk patients, the question is, how much do you do? We could have done less, could have stopped shorter. Concern about developing a recurrent distal junctional problem. It definitely was in my mind. Similar to the last case by Dr. Bourbon, we didn't cement that LIV because of the current infection. And then this patient had flattening of the subaxial spine, hence the combined deformity. So that's why we couldn't pull his head back all the way. We could, if he wasn't fused in that subaxial spine, we would have been able to get some more lordosis to the subaxial spine. But he did well as he could have. And I think it just highlights a lot of the topics that we addressed in the talk in terms of where to stop, proximally and distally, and options for correction. Happy to take any questions.
Alekos, Jack Ziegler. I just had a question for you on using the rail technique. Would you not have much better control if you did it bilaterally with compressors? I just worry, if your rods aren't exactly aligned, that, doing unilaterally, you may get, a cogwheel or a sudden jump or something that you could control much better if you did it bilaterally. Do you not have room or just not the equipment for it?
Yeah, great question. Thank you for that. So my technique is I have two rails in. I will loosen the contralateral rod that I'm not working on at the time. We'll then do our initial compression on one side, and then we'll stabilize it and then go to the other side and do the same. So depending on what the deformity is, you can tailor your treatment, can go back and forth. Once you've compressed it, if you want to get a little bit of lengthening anteriorly, then you can do your cantilever. So it does require some back and forth, some rod exchanges. But yes, I agree with you. Having it unilateral, I don't think you'd get the outcome that you're looking for, and would probably be probably riskier from a neurologic standpoint. Well, we've reached 6 o'clock, and thank you again to the Seattle Science Foundation for this opportunity. Thank you to everybody who attended. We're happy to address any questions offline, but it's a real honor to present to you guys again, and looking forward to the next time.
You guys did a great job. Thank you. Thanks so much.
Thank you.
Solid work, guys. Solid work.
Great to see everybody.
Alekos and
Good
company.
night, everyone.
Good night.
Good night.
Be well. Good night.